Hi, it's Dr. Dailey. It's my pleasure today to introduce Dhara Shukla, who will be joining me to discuss tourniquet reassessment and conversion. This is going to be a procedure that will be new to us, that will be specific to the REMO and AAREMS regions. As you know, our current bleeding and hemorrhage control protocol, which applies to all levels of EMS providers, includes the use of tourniquets. And one of the things about tourniquets that's important is we include under key points and considerations the fact that you're not supposed to remove a tourniquet that was placed for life-threatening bleeding. One of the things that we do know, though, is very frequently tourniquets are applied for things that are not life-threatening bleeding. And after tourniquets have been placed, in many cases, if we reassess that application, we may be in a position where the tourniquet can be removed. There are a lot of different reasons to do that, and Dhara is going to take us through those.
So tourniquets in general are highly effective and rapidly deployable life-saving measures for hemorrhage control. And the use of tourniquets is a cornerstone of hemorrhage control in situations that are involving life-threatening extremity bleeding, especially where hemorrhage control is necessary in the more immediate setting. Prolonged application of a tourniquet, however, can result in increased pain and ischemic limb injury, nerve damage, and it also increases the risk of limb loss if the tourniquet isn't reassessed in a timely manner and taken down if necessary. So I did research regarding the information that I just shared and kind of reevaluating the use of tourniquets and when takedown may be appropriate and kind of the outcomes that could result from that. So I did a multi-center study to assess whether law enforcement officer versus emergency medical services places tourniquets are misplaced. And data was collected from 4 level 1 trauma centers, and that demonstrated that only about 30% of tourniquets are placed in cases of severe life-threatening hemorrhage, while the other 70% are in these more less non-life-threatening cases that I kind of referred to earlier. And the tourniquets that were replaced by law enforcement officers were more likely to be placed in cases that were less likely to be life-threatening, less severe hemorrhage, or there wasn't a defined or named arterial bleed involved. Tourniquets that are placed in emergently high-stress situations may not be required for adequate hemorrhage control, but oftentimes they might be applied in these high-stress situations as a means to kind of stabilize the patient in the way that seems necessary in that moment while dealing with other situations that are on the scene. However, given the fact that only 30% of the tourniquets in this study were applied in cases of life-threatening hemorrhage, it shows for room to improve. So the tourniquet conversion procedure is the reassessment and removal of a tourniquet once bleeding is controlled and alternative hemostatic measures are in place, such as wound packing or direct pressure dressings. And this procedure reflects the practices and recommendations from military and civilian trauma literature, including the Tactical Combat Casualty Care Guidelines. And this is supporting this early removal of tourniquets and early reassessment of tourniquets to better care for patients in the long run. So as I stated earlier, so taking down a tourniquet earlier, if it's not necessary to control a bleed, can help reduce ischemic time and chances of tissue injury on a limb. And it also reduces patients' pain and need for excessive analgesic measures. It also can decrease the risk for complications like a reperfusion injury, rhabdomyolysis, or potential amputation even. And it improves the overall outcomes for salvaging limbs. And it helps standardize care and reduce variability in clinical decision-making, both in the pre-hospital setting, and it also can help in the hospital setting as well. So this procedure, which I'm about to go into a little more, defines clear steps and safety parameters to help in determining when it's necessary to reevaluate a tourniquet and when it's reevaluate a tourniquet, decide whether it can be taken down or decide that it needs to stay in place until the patient arrives to the hospital. So this will provide clear guidelines to kind of help in better understanding that and directing care in the pre-hospital setting. So part of this assessment and evaluation of the tourniquet, one initial thing to consider is that if the tourniquet was placed proximally, for example, high and tight, you should consider placing another tourniquet 2 to 3 inches above the wound if the wound is still hemorrhaging, and then you can remove the emergently placed tourniquet. And you also want to assure that the tourniquet is appropriately placed. A tourniquet should never be placed over a joint. It should be about 2 to 3 inches proximal to where the laceration or wound is. And then it's also important to expose the wound and ensure that there's no active arterial bleeding. If there's active arterial bleeding, you're more likely to want to keep this tourniquet in place. But if there is an active arterial bleeding, then it's likely that the tourniquet may be able to be removed and isn't necessary, which will help improve patient outcomes in terms of pain, reperfusion injury, and the other complications that I discussed earlier. So you want to evaluate the location of the wound, consider the anatomy that is in that area, and the mechanism of injury. If there are major vessels involved, that could help direct your care as to whether a tourniquet is necessary, and also determining if lower levels of hemorrhage control, such as pressure dressing or packing the wound, may be a better form of care. If there is arterial bleeding present, you want to tighten the tourniquet, and then you could additionally pack the wound as an extra measure to help with hemorrhage control, and then wait for about 3 minutes before considering tourniquet takedown to ensure that this pressure dressing or packing the wound has taken care of the current bleed. And if there isn't any active arterial bleeding when you check the packing, then you can proceed with the tourniquet takedown. So in order to take down a tourniquet, you want to slowly loosen the tourniquet and continue to observe the site to make sure that there isn't any signs of continued bleeding. If bleeding is still there, then you want to stop releasing the tourniquet and try to control the bleed with direct pressure. And if the bleeding is now controlled with the direct pressure, then you can assess distal perfusion. And if there is distal perfusion, then you want to apply pressure dressing and leave the tourniquet in its current position. However, if there isn't any distal perfusion, then you can relax the tourniquet until perfusion is restored to prevent ischemic injury. If bleeding isn't controlled with direct pressure, then you want to replace the tourniquet at the previous tension that it was at so that the tourniquet can take care of hemorrhage control. And if the conversion fails and you are not able to convert to tourniquet takedown, then you can reattempt again after about 15 minutes for one more time. And you should try to remove a tourniquet, convert the tourniquet to a different form of hemorrhage control in less than 2 hours. So if loosening the tourniquet to allow for blood flow to the injured limb results in bleeding and does not show any sign of the hemorrhage stopping, then you should stop further attempts of tourniquet takedown, as this is a sign that this is probably a more life-threatening bleed. If the tourniquet is released and distal perfusion is restored, then that could cause some pain in the affected limb now that the patient has more perfusion to that area. So you should be prepared to provide some analgesic medications appropriately. And if the tourniquet has been in place for more than 2 hours prior to the attempted conversion, then you should proceed with the crash injuries protocol. And if bleeding persists after the placement or replacement of a tourniquet and the initial tourniquet cannot be tightened any further, then a second tourniquet should be applied as another form of hemorrhage control. So that means there would be 2 tourniquets in place to control the bleed, and then the second one would be placed proximal to the first tourniquet. And you want to assure that there's appropriate packing. And if there is an amputated limb, you should never attempt to take a tourniquet down. The tourniquet should be close to the site of the amputation, but still it should never be over a joint. So the key to this procedure is to assure that their hemorrhage control is always maintained. So tourniquets are great tools, but they have limitations, as I stated earlier. And EMS providers have additional opportunities to provide hemorrhage control in extremities through wound packing, direct pressure, pressure dressings, etc. So you should make sure to document the placement of the tourniquet and the conversion of the tourniquet as appropriate, along with the timestamps.
All right, thank you very much. This has actually been a treat. There are very few times where we get the opportunity to get somebody that did the primary research that's ultimately driving a change in our procedures. So the opportunity for us to convert and then take down tourniquets is something that will be a procedure in the AAREMS and REMO regions, and look forward to seeing this expanded across New York State and ultimately across more of the country. Of note, the procedure itself is very similar to one that was done quite effectively in the state of West Virginia, where they actually led with this process. But now we have the primary research that was done here by Dhara with partnership from Inova, George Washington University, University of Rochester, and the trauma team here at the Albany Medical Center. So again, Dhara, thank you very much for doing this. Really appreciate seeing the rest of your career take off as you continue to advance medical care. Thank you.